Ocular surface squamous neoplasia, or OSSN, is the most common non-pigmented tumor of the ocular surface. OSSN is an umbrella term which describes a spectrum of benign, pre-malignant and malignant epithelial lesions of conjunctiva and cornea. It encompasses squamous epithelial lesions of ocular surface ranging from mild dysplasia to carcinoma in situ and squamous cell carcinoma. Meticulous clinical examination can help in clinching the diagnosis of this common ocular surface tumor in clinical practice. Although a number of management options exists in the armamentarium of the treating oncologist depending on the nature of the lesion, surgical excision with a no-touch technique is the standard of care for localized OSSN. This video illustrates salient points for complete protocol-based surgical excision of these tumors, appropriate handling of the tissue sample, and pertinent points to look for in the histopathology report for planning adjuvant treatment. The goals of surgical management are to excise the tumor with clear margin and to make any remaining tumor cells non-viable. The first step before the management begins is to determine the extent of the tumor clinically, which can be done under the microscope during examination. A good clinical documentation goes a long way in adequately managing these lesions. A 4 mm wide surgical margin is taken from this clinically determined tumor extent, not just the nodular lesion. A bipolar radiofrequency electrode is used to mark the surgical margin. The radiofrequency electrode is used to incise and excise the conjunctiva till the limbus. Adjacent anatomical structures must be carefully dealt with during the surgery. Adequate hemostasis should be achieved to keep the surgical field clear. Cellulose sponge dipped in absolute alcohol is applied to the leading edge of the corneal component. A crescent blade is used to scroll off the loosened epithelial layer off the Bowman's membrane, taking care not to damage the Bowman's layer, which acts like a barrier for the tumor invasion in the corneal stroma. A thin scleral base is excised while completely excising the tumor. The sclera and the limbus are scraped after the lesion excision. The excised sample must be sent for histopathological evaluation on a Whatman's filter paper. The sample is left to air dry to facilitate its adherence to the paper while the next few steps of the surgery are completed. Double freeze-thaw reverse cryotherapy is done to the posterior surface of the resected edge of the conjunctiva. Dense ice ball formation takes almost 15 seconds and a spontaneous thawing is then done. Ocular surface reconstruction is done using amniotic membrane graft and tissue glue. Once the tissue sample is excised, special care must be taken to send the sample for histopathological analysis. It is important to label the filter paper properly, lay the tumor flat with proper orientation, and ensure that there is no curling of the margins of the tumor. The sample is sent in 10% phosphate buffered formalin with appropriate labeling of the specimen. Any extra margins of the conjunctiva excised must be separately laid flat and marked on the filter paper. The report must include a comment on margin and base of the excised specimen, whether free of tumor or showing positivity, so that correct protocols can be followed for deciding about adjuvant management options, thus providing best management outcomes and reducing the chances of recurrence in these patients.